Welcome all of you. Any question before we move to the next topic? Any feedback or anything that you want to ask or say? Okay.
No, ma'am, nothing specific.
Thank you. So I'm going to share the screen with all of you and start with the presentation because I want to really save time on this so that we are able to, include both the presentations. Yeah. Okay. So as I said that we are going to talk about patients hands off. Are you able to see the screen? Great. Yeah. So I think this is one topic that is required to be, included in almost all training programs because usually we are not very, particular about handoff and we don't know the seriousness of the issue. And usually, when I take sessions for nurses and if I ask them, how do you take over or handover? So mostly they'll say we take over, we go bed to bed because that's the protocol. So if I would ask them, okay, in case if the next nurse comes little late, so how do you manage? So, ma'am, in that case, we take handover, at the nurses station. Okay. Suppose if the next nurse comes slightly later than that, then how do you hand over? When then we hand over in the changing room. While changing, we hand over the patient. Suppose if she comes further late, then how do you hand over? The response is, ma'am, then we hand over at the gate. We tell everything we have written in the handover book. Kindly read, and in case if you have anything to ask, you can call me and talk to me. So that's how you can see the quality of handover that's happening. And when I ask doctors, how do you hand over? A lot of time they'll say our handing over is like we say, they're all fine. Take care of these two people. I want to hear from all of you. What is your experience? What challenges do you see in your setup in terms of handing over? If one by one, if you could share your experience. Keep it short, but something that would really give us an idea about the challenges we all are experiencing. So if I may ask Dr. Samira, what is your experience with the challenge in handing over?
Yes, thank you so much. Really here, there's no any training regarding how should be the handoff. And it is completely unorganized. So there are many faults, mistakes happen, and nobody say that this is due to the absence of training of this very important moments during healthcare. Yes.
So that means we are sailing in the same boat like you. I completely agree. Yeah, I completely agree. So Renuka, what challenges are you facing? Because I know you are into quality and you are deeply into, all these things. So what is your learning?
One common NC we always, have to be worried about is that I agree with you. Nursing does some, they do give the handover at least in the form of a register and shift to shift thing. They do document it in some form. And they're quite religious in this thing of by rote telling, from one shift to another, you will see transition time 2 to 2:30, they'll be all busy outside, then evening, then everything. Doctors, it's a different story. And I really remember the first set of even DMOs when we were working. I mean, not this thing. I first made a form, like a checklist form. कि आप सिर्फ tick कर दो कि मैंने, I have just informed this. They said, no, we can't do this. Then they said, okay. Then I said, I put a simple notebook, you something like that. Then it's just that you have to get the buy-in from them, ki how you want to do it. And then it's always oral. Then they said, no, we'll have a WhatsApp group. We are having it. We are communicating to our team, whatever this thing. You only need proof now that we are doing handover. Is this enough? I said, okay, fine. I don't know.
My goodness. I completely understand your plight, how you must be feeling. Yeah. So Dr. Shukla, how are you handling it Because I'm sure even in your hospital you have this similar situation, but how are you managing it?
Ma'am, again, ma'am, it's all about to the different systems, the corporate groups and the government system and the system which have been put by. I have seen the role of medical superintendent of the hospital very important in this aspect.
Yeah.
If the MS decides that this has to be done in this way,
Yeah.
and because they are under the direct control, these things, then
Yeah.
these are done. If it is like left over to like, okay, you have joined, now it's
Yeah.
up to you. So then again, these are the shortcuts. What technology has made our lives easy,
Yeah.
but then we have deviated from the protocol kind of things.
Yeah.
So the actual handover, which should be patient wise,
Yeah.
it's not an organized thing. And the most important thing you have included in, ma'am, in your training part, handover being very important.
Yeah.
Because you know the gap in the communication.
Yes.
Whereas the healthcare profession does not consider it to be that important vital aspect that has to be taken care of.
Yeah. Okay.
So ma'am, you have taken handover like emergency. So that is one place again which needs a lot of working, because again the patient is in transition phase.
Yeah.
So ICU, very important handover is ICU, the new patients.
Yeah.
So there are different set of patients, a routine ward with normal patients, that handover with on routine drugs and not on any
that may not
critical,
be very challenging, that may
very
not even
challenging.
need that much of seriousness, but especially when the care area is changing from one place to another or going from one hospital to another, there can be complete loss of information if you are not handing over and taking over properly.
And especially, ma'am, when there are like important investigation where there have a lot of small hospitals have come up, where they doesn't have all the facilities under one roof.
Yeah.
So the patients need to go to different units for investigation that time. Then one handover is missing when the patient has to be shifted to higher setup of same organization.
Yeah.
So that is also one area,
challenge.
one challenging area, or the discharges. So these kind of things are there which needs a personal intervention and where you feel and you can contribute to.
But I think the point that you have raised is very relevant. If the top leadership enforces this as one of the essential requirements, I think slowly people will fall in place. Especially maybe you can't, rein the consultants, but even if the handing over happens at the residents level, because most of the primary care is provided by the residents, and they can be controlled because they are young and they are juniors, so they can't, work on their whims and fancies. Only thing is, if that protocol is in place and the senior leadership is in serious mood to implement it, I think a lot of these lapses can be looked after. I completely agree with what you say. So anybody else who would like to share their, learning or their experience about handover other than what we have talked just now? Yeah, please, Dr. Santana, go ahead.
Ma'am, I just wanted to share my experience. I really don't know whether it's happening now, but I'll tell you that this is way back, like more than 27 years back. And my father was in railways, and he was the deputy CMD. When I used to go to the hospital, I used to see this process of this handover and takeover between doctors. And then when my daughter and my son were born, that is 23 years back and 18 years back, I still have those files with me, in which I have seen a very clear-cut communication, not only between the nurses, but even between doctors. Wow. And this is in a setup like railways. I don't know whether they still continue that, but I remember that during those days, they had a proper communication and they had a step-by-step communication method at that time. So
but Santana, was that in your case alone, or was it being done for every
No,
patient?
It was being done for everybody, ma'am, because I was a frequent visitor to the hospital because I was staying in the hospital campus.
Because you were daughter of a senior, member of the
administrative. Yeah. Yes.
So at times they are more careful and more systematic in their approach. But I don't doubt that if you say that they were doing regularly, so maybe they realize the importance of it. But that could be one sporadic example you can
No,
see.
ma'am. That's what I'm saying. Like, now, since I used to visit the hospital frequently because my sister was also working over there, and I used to sit on the table and I used to just go through whatever they are doing and all. So I have seen it many times. So
So
at least
good to
I
hear.
was that way vigilant on what is happening, and
Yeah.
I used to wonder that why is
Mhm.
this happening and why are these doctors talking the same thing? He's going to go and see the patient any which ways. So what difference he
Mhm.
makes that? Why is
Mhm.
this doctor telling him what has happened? And
Mhm.
everything is written. But then I've seen this kind of a communication at that time.
So good, so good, so
So
good.
there are some certain working patterns, but it is not like
Completely, I
as
agree. Yeah.
unanimous at all.
But this doesn't have to be on the whims and fancies of anybody. This is like you give medicine, you need to hand over. That it has to be that seriously taken. So anybody else who has anything to say quickly about their handing over experience or their thoughts about it. Otherwise, I'll move on to the presentation. Should I? Should I move to the presentation? Okay.
Yes,
So I'm
ma'am.
sharing the screen once again with all of you. Gulin, do you want to say something?
Ma'am, I think it will come from a patient's perspective because um, I'm going to compare Western and the healthcare systems in India. I feel that uh, the formats that you've given in the notes, ISPAR, I think that's what was followed because I was an international student and I remember when the shift changed, my nurse, she used a form and she sort of filled out everything and because she required me to sign it at the end before she shared it with the nurse. So I remember the form, but based on what I saw when my mother was admitted in Fortis Mohali, I think that was a very poor experience because I felt that they were misinformed in many levels. I'd come back from overseas and I'm sorry, everyone, I'm taking a lot of time with this story. So I'd come back and I was told that my mother has been admitted for appendectomy. And when I came back and I asked the nurses in duty, nobody was aware of why the surgery was being delayed. And I had to wait overnight for the doctor to come and explain why it was delayed. And that sort of gave me an impression of how poorly
Informed there. Yeah.
Yes.
They don't get even involved with the basic information of the patient, which is essential to provide accurate care. Knowing the patient's name, age, sex, diagnosis, and the treatment and allergies. This is some basic information. I mean, we should have about all our patients whom we are attending. Because, I mean, you can't go back to the case sheet every time and look for the information. But it is not just between the nurses, even doctors do not know their patient's name. They don't even recognize them well. Bed number 6, bed number 8, bed number 12, that is how they refer. वो appendicitis वाला पेशेंट, वो gastritis वाला पेशेंट, वो renal colic वाला पेशेंट. This is how they name their patients. I think that I completely understand what you are trying to say. So I would like to now talk about what exactly is handing over and how it should be done. One is that we will get to see there are a number of ways we can actually implement it and we can make it happen. But only thing is, initially there will be resistance, there will be challenges. But if we decide to, make it happen, it can happen. Like Dr. Hemant said that if the senior leadership is, in favor of having a proper handoff, anybody and everybody can be brought to, in the.
Yeah, I think once the HOD is involved, no, then it is more easier to implement things.
Yeah.
Direct to them, we tell them, then the team follows, like it's done.
Exactly. See, the other reason is people think that whatever I'm doing and in whatever way I'm doing, that is all right. Problem is we don't want to research. We don't want to do any study. We don't want to expose ourselves. So as a result, we don't get to know the amount of errors we are making in that process or what is faulty in our process. We just assume that what I'm doing is right and that should go on. Therefore, we never get to know the number of errors we are making in faulty handover. So if I ask you to read this case where, like, I mean, this is handover being given or taken by a doctor or a nurse. So what do you think out of this the person who is taking over is going to remember?
The underlined part?
Exactly. Exactly. So if a person reads everything or listens everything, the basic information that the person is going to retain here is, oh, this patient is getting discharged tomorrow. So not much has to be done. And if you will look at the, the picture, in the first one, the sender is saying a lot of things to the dog, but dog only understands the word that is his or her, its name. So you may say 100 things, but the receiver is going to do selective listening. As a result, unless you are very systematic in telling what you want to say, it's all going to go in ear, and the person is going to listen to only what the person wants to listen. So this is, the feeling that patient care handoff is a critical safety and quality problem. As I said, it's considered Bermuda Triangle of healthcare. That's because 70 to 80% of the information gets lost in the process, and the patient, is handed over from one care area to another care area. According to a study by JCI, they studied around 3,000 sentinel events for a span of almost like 10 years that happened. 65% of them reported poor communication as the reason for the sentinel event. And out of that, 50% was during the handoff. So you can imagine the seriousness of the problem. When the proper handover is not done, how it can, lead to ultimately loss of information that's so essential for the patient's safety and continuity of care. The problem with the handing over is, like you have mentioned just now, one of the reasons is that we do not have structured, effective ways to hand over. Plus, the variation in the seriousness is very different. For example, if it's a medical ward, say with regular patients, so maybe not much has to be done. But if it is ICU or it is any other critical care area, for example, OT to ICU or ICU to ward or from one department to another, there you require really detailed handing over. So we do not have, customized kind of handing over tools which actually help us to hand over completely. And you also must have seen it is always taken as one-way process. The person who is handing over is supposed to hand over. Whereas the reality is handover is never given. Handover is always taken. That has to be the seriousness, required to take over. Another problem is time, commitment, and process change. So when I talk about time and commitment, I want to ask you, in how many of your hospitals have you kept some overlapping time between the two set of staff who are going to hand over or take over? So even if I talk about nurses, in how many hospitals do we have that half an hour to 45 minutes of overlapping time where both the nurses are there on duty, but they're together and they're actually handing over? So for example, even if you have a bed strength of say 50, to hand over a patient, you require at least 2 minutes, if not much. At least telling this much, okay, this is the patient, this is what we did, this is what happened, this is what needs to be done. At least 2 minutes per patient. So 50 patients means around 100 minutes. 100 minutes means around 1.5 hours. So even if you have not kept 1.5 hours, at least if you have some time which is overlapping between the two shifts, you can look after. The nurse who is on duty or the doctor who is on duty is eager to leave as early as possible. So if you ask that person, suppose if his or her duty is from 8 to 2, and if you tell that person, instead of 2, you have to go at 3 o'clock, tell me who will be ready to stay back for 1 hour. Similarly, the next shift person is going to come at 2 o'clock. If you ask that person to come at 1 o'clock because you need to take over, nobody is going to agree with you. So that means very smartly, you have to change the shift timings in a manner where automatically they are there for at least half an hour to 45 minutes together and nobody's in hurry. Person who is to go off the duty knows that I am going to leave at 3 o'clock. So my duty is not from 8 to 2, my duty is from 8 to 3 or maybe 8 to 2:30. And the next person who is coming on duty should know that my duty is not from 2 o'clock. I have to be here at 1:30. So 1:30 to whatever their evening timings are. How many of you have that kind of arrangement in your hospital?
This kind of arrangement is not there. And another thing, again I say, the psyche which we do, like the person who is ready to do, we have got that mindset. 15 minutes, we are again home. We are ready to launch.
Go.
And the person who is coming will land up just on the time, or maybe 5 minutes later. So with a guilt kind of a thing at time, and just okay.
Sorry, I'm late.
Sorry,
I'm late.
and just the smart thing which the management can do, where I see the leadership. If the nursing superintendent of the hospital does take a round daily, or the MS takes a round daily, so these things will looked after, and she can ask about the patient any day. So everyone is on this thing, NS can ask. So that kind of things work with nurses and MS.
Just by physically taking a round also, you can bring lot of changes in the system. There's no doubt about it. I completely agree. I wish we had time. I would have shared my experience, what happened at RML, and how they are giving a mass kind of a message and how that is misleading. But we don't have time. Otherwise, I would have gone into that. But if I talk about the handover specifically, unless you will have overlapping time, you will never be able to implement it in a serious manner. So if you really want to consider it, you'll have to really bring in some changes. Maybe if you think half an hour time is enough to hand over, then 15 minutes from both the sides have to be sacrificed, and they will have to, do overlapping duty so that they get half an hour together to actually take over and hand over seriously. Plus, it requires process changes. As very rightly said by you, there's a mindset. The person who has to go wants to go as early as possible. The person who has to come, he or she wants to come at the nick of the hour, or maybe even if possible little late. I'll come little late. I mean, they'll say and then they'll come little late. Okay, you tell the other nurse I'll come and take over, or you tell the doctor I'll come and take over. So, and that requires real process change, mindset as well as the process change, which is not there in most of the healthcare facilities. Again, as I said, there is extreme variability and uniqueness of handoff required because of the care areas. In critical areas, you require more complex handover. In simple and easy areas, you require simple handover. So there's huge variability. And that's why, we have not been able to come up with any, one or at least multiple, handing over tools, depending upon the requirement of the situation or of the department. And also, we do not have any focused research on healthcare handoff as of now. We do not have many studies that have actually calculated the number of faults or failures or lapses because of incomplete or inappropriate handover. This one study I want to share with you just to highlight the importance of the right way of handing over. Now, if you remember, we did that activity where very in the beginning, I think it was the first session where we did that Chinese whisper activity. So in that, if you remember, we were just verbally sharing the information. But the first person who got to see the slide had all the information. Same way, if I had shown this slide to every person who came in, probably everybody would have had the same set of information. So that's the importance of, audiovisual information, not just listening to, but also if you're able to see the document. So in this study, this is what exactly they did. What they did was they took 12 simulated patients and they did 5 consecutive handover cycles. And they tried 3 different styles. So what were those 3 different styles? In first one, it was verbal handover. So it resulted in loss of all data. And this we have seen in the Chinese whisper activity that we did. The second one is note taking. That means you are just noting down, but you are not verbally handing over. So in a lot of, hospitals, when I ask them, how do you hand over? Ma'am, we record everything. We record everything on paper. But who reads? So again, it says clearly that you lose almost like 31% of the data in that. A lot of time, the person who has done the initial assessment will write hypertension, diabetes, thyroid, convulsions, or maybe taking treatment for, Alzheimer's or whatever. Sometimes people don't read their case sheet, don't realize how multiple comorbidities could be existing and they need to be addressed. Then the third style that really worked was standardized format with verbal handover. And in verbal handover, the idea is that both the parties should communicate. It's not just one person speaking and the other person listening. The other party is supposed to be asking, clarifying, and in case if nothing, like if you're not sure of the information, you verify so that you make sure that you have taken the correct information. And they saw that it resulted in minimal loss. So that means ultimately, this is the way we can actually make sure that we hand over in the right manner. So because of the ineffective handover, a lot of lapses happen. There can be wrong treatment, there can be delay in treatment, there can be severe adverse events, lot of patient complaints, patient dissatisfaction, and you all know. So what kind of ill effects have you seen in your setup? If you could write in the chat box, what kind of consequences have you seen because of ineffective handover in your setup? Write in the chat box. It could be even your personal experience. Not that you are working in the healthcare, but like, for example, some of you are not directly every day working with the patient, but then I'm sure you could have been the victim of the situation. You could even share that. Yes, emotional distress to the carer. Yes, definitely. Families under always this fear. Suppose if the next person does not know what happened in the morning. Delay in operations due to pre-operative investigation. Yes, a lot of time this will happen. Patient was kept empty stomach, but the investigation was not done because the next nurse didn't know this. Okay, chaos and high risk probability. Yes, very true, very true. Then missed pack removal before discharging. Yes, because it was not communicated, it was not informed to the next person. Anybody else who would like to share? So in my case, I can quickly share my sister-in-law. She was admitted in a hospital, for bariatric surgery. So she had severe respiratory distress, and since she was obese, so she had a lot of health issues at the same time. So she was admitted in the ICU so that we could settle her, and once her vitals and everything are fine, then we'll put her for surgery. And at night, the nurse forgot to give injection Lasix, because normally the last dose of Lasix is given around 6 o'clock in the evening. She forgot to give it, and then when she was going, she informed the night nurse, "Oh, I forgot to give Lasix, so please give Lasix." She said, "Okay." She gave Lasix at 10 o'clock at night. Now, whole night, my sister-in-law, she was, asking for bedpan. She was on BiPAP, so she couldn't get up and go to the washroom. She needed bedpan, and whole night she kept requesting, the attendant to provide, bedpan. And anybody who on the night duty is not happy, getting up and serving. So somehow, I mean, when I met her in the morning, she told me about everything. She said, "This is what happened with me." So a lot of time, patient suffers, family is under distress. Like you said, discharge process get delayed. Very true. Again, in another case, I think I shared last time also, my brother was in the ICU. The morning doctor said discharge. The nurse did not enter in the record. The resident did not enter in the record. So the cycle and the meter was on of the ICU. And the ICU charges and the room charges are very, very different. So when I went in the evening, I asked, why haven't my patient been discharged? They said, it's not on the record. And I said, no, in the morning, the doctor was on round. We asked him for, discharge. And he said, yes, you can, we'll move him to the ward for a room for 1 day. And then tomorrow we'll discharge. So what I'm trying to say that a lot of these things happen. And I'm sure a lot of patients are aware of the fact that their care is getting compromised. But the thing is that they don't have much say in the system. As a result, the healthcare cost goes up, the length of stays goes up, the patient gets readmitted, patients get discharged late, surgeries get postponed, investigations get postponed. So a lot of these things happen because of the improper handing over. So we really need to work on the system, create the culture of proper working around the patient. And then I think at the individual level also, we require a change in mindset of people. I think that's where we need to really focus. Now, if you see, handing over is more like a painting a picture. The person who has come has not seen what happened in the last 8 hours. And the person who is going knows everything what happened in the last 8 hours. So that means the person has to be really good at painting the picture, giving a bird's eye view of what happened in the last 8 hours for every patient. So you have to actually give all relevant information in a systematic manner. Also the specific directions for the next action, whatever needs to be done. For example, if the evening staff is going and she tells the night staff that this patient has to be kept empty stomach, she has to undergo barium meal, or she needs to undergo endoscopy or x-rays or ultrasound or whatever the investigation that needs to be done. So all those directions need to be given very clearly so that the patient's care is not delayed or not compromised on that front. And then also, you want to say something, Santuna?
My hand started paining, ma'am. I've been for a long time. Okay, I just wanted
I'm so sorry, I could not see you because you were not visible on my. I'm so sorry.
Okay, ma'am, the most common things that the doctors do is CT all.
Yeah.
So I have seen in many of the notes whenever we go for the hospital audits,
Yeah.
even if it is a handover, it is written as CT all. So this is one thing.
Tell for everybody what is CT. Tell for everybody what is CT.
Continue treatment.
Yeah. Or but CST. A lot of times they'll write CST. Continue same treatment. Yeah.
Same treatment. So they don't understand this. CT all according to them is like, nah, that's everything is fine. You don't have to worry. Just keep going ahead with whatever is happening.
Yeah.
So this has been a very common thing, and this is where generally is always a matter of concern whenever I go to any organization for audits and talking to them.
Yeah. So true. I completely agree, because we don't sometimes see how the other person is, understanding or viewing, and as a result, there's huge miscommunication. Like that's the major, matter of concern. So at the same time, the sender needs to check what is the receiver understanding. Like we have been talking about, teach back or ask the person, what do you really understand from what I have said? So at the same time, receiver also has a responsibility. And if you see, usually receiver is either nodding or listening or not listening. You are not very sure, at least maybe pretending to listen. A lot of time I have seen also saying, tu ja, you go, I'll manage, don't worry, I'm here, I'll look after. Go. Where do you want to get date? So they want to oblige the person by sending the person early, but not, taking the handover seriously. So a lot of even time these lapses you will see. But the receiver is supposed to be listening, ask questions if something is not clear. And also you need to have a system to remember important information. So even having a, like you have a handing over book, it's good if the person who is taking over should be writing in her handwriting or his handwriting, that okay, for this patient I'm supposed to do this, for this patient I'm supposed to do this, rather than keeping it ready for the next nurse or doctor. It's better if the next person who is coming in should write in his or her handwriting. I think that will be a good way of making sure that the person has noted down everything. And then of course, read back or teach back. That's one good way that you can make sure that the person has actually understood. We have to actually learn from these organizations what is called handing over. Organizations like nuclear power and especially aviation industry, even dispatch industry. If you see the parcels we get, thousands and lakhs of parcels are, collected, segregated and dispatched. And very rarely they would go, they will get misplaced. They are done so systematically. That's because they are taken over and handed over very, very carefully. And actually, healthcare industry is considered more dangerous than working in nuclear industry and aviation industry. That's the reality. 1:33,000 errors. 33,000 errors happen in healthcare. And then you will see one error happening in any of these industries. So very rarely you will see any air crash happening because of the error of the, there could be many more reasons, but it's usually not the, and even when we are in the flight, we see so many people coming in and, having the checklist in their hand, and they'll be ticking mark. Okay, this is checked, this is checked, this is checked. Unless they sign and hand over that permission to take off, the flight cannot take off. So that's how actually, we should be also, doing proper handing over if we want to make sure that the patient does not get, hurt. Only thing is probably in the patient's case, it is the patient who suffers. If you talk about the aviation industry or the nuclear industry, the person who is handling those things are probably directly affected of the consequences of mishap. So maybe that's why they're doing it very seriously, because ultimately their own lives are, at stake. Maybe this is just one of the, thoughts that I have. So handing over, what is the definition of handing over? What is the definition of handing over?
Passing off of communication of data and being communicating it in the verbal, written and digital form.
Okay, correct, very right. So it's like, transfer of duties, rights and obligation from one person to another, from one team to another, from one care area to another. And if you can remember two things, I think we will never fail to hand over properly. One is continuity of patient care, and second is safety of patient. So when we are taking over or handing over, I think if we can remember these two major objectives of proper handover, we can never fail. One is continuity of patient care, and second is safety of the patient. And if you are able to ensure that, I think most of the handover can be very accurate and precise without any faults. So where all have you seen handoff? Can you write in the chat box? Where all have you seen handoffs? In which care areas, from which care area to which care area?
Ma'am, ICU to room.
Okay, that's one. You could write in the chat box, or maybe it's okay if you have spoken. Yeah. So OT to maybe ICU or post-op, or to ward. Yes. Shift change is very common, very true. I think that's the most commonest place. Yeah, OT to recovery room, correct. Okay, emergency room to OT, very right. Then ward to ward, yes. At the time of discharge, refer to general practitioner or family doctor, yes, for ancillary care. Yeah. So what else? Yeah, hospital to hospital, very true. I think that's also very common. Department to department, specialty to specialty, very right. Okay, referral to other hospital, yes, other specialties, other higher setup, that's also very common. So that means these are all different, types of handoff that we may require, and very rightly, yeah, within lab. So can you specify, Dr. Santana, though I understand, but for everybody to understand what exactly we mean by within lab, because this will be, yeah.
Yes, ma'am. Many a times, like if there is a glucose tolerance test, GTT, for a patient. So if there is a shift change and the rest of the samples need to be taken at the patient's bedside. So this is also given in a handover. Or if there are samples pending, or if there is, for example, in microbiology, if they need to go and identify if the growth is there or not, and then put it for sensitivity. So these are a lot of handover things that take place in the laboratory area.
Very true. Very true. Also in lab,
urgent reports also, Dr. Santana.
Yeah, urgent reports also.
Yeah,
and
critical
also,
alerts.
Yeah. Also in labs, there are critical, values, and that need to be reported immediately to the concerned doctor. So even that comes under handoff, because you are supposed to be reporting it at the earliest in the right manner to the right person, so that appropriate action can be taken to ensure patient safety and continuity of care. So as you said, most of the areas you have covered. Just to look once again that we haven't missed anything. Yes, nurses shift change, level of care, OT to ICU, doctors shift change, physician transferring care from one coverage care area to another, patient transferred out and transferred in the hospital. Then on-call responsibility. So when you are sending a referral or a call to the other specialist, even that's considered on-call responsibility, and that's part of handoff. Then critical reports, like we talked just now. Then hospital transfer from one hospital to another, or from hospital to home, or like to general practitioner or local practitioner. Then from one department to another, for example, from your care area, you're sending the patient to radiology or to physical therapy, even that's considered a handover. So if I give you a small activity quickly, and if I move you to a breakout room, do you think we'll have time to do that, or you want me to do it right here with all of you? I think to save time, we will do it right here. The activities, for example, is a simple case of, say, medicine. So what all do you think should be component of ideal handoff right in your notebook? What do you think should be there, or is the minimum thing that is required in the ideal handoff? Can you make a list of things in your on paper? I was thinking of sending you in pairs to the breakout room, but I think we will be short of time, and we can't spend time on that. There are more slides to show you. And this activity you can do when you conduct a program for your audience. This is a very good activity. I've done it a number of times, and it really brings in a lot of insight, and also collaborative method. I'll tell you how I do it. So just tell me when you're done. In the chat box, you can write done, so that I know that.
Ma'am, how do we present it? Do you want us to write it in the chat box, or how do we do it?
So no, you write in your notebook. It's okay. I will be showing you mine, and then you can check whether that is part of the list or not with you. But I'll tell you how I do the activity. That's a different way. I'll explain you that. But after you have finished, just tell me done, so that I can move ahead. Yeah. Renuka has done already. So you just have to list down 5, 7, 8, whatever you think should be part of the handing over. So suppose if you're creating your own handing over tool, so what all do you think should be there in the tool? Two people have done already. Okay. Dr. Samira has also written. So this is not for the referral I'm asking, Dr. Samira. This is in general. Suppose if you are suppose a nurse is handing over a patient to the next nurse, or a doctor is handing over the patient to the next doctor in the ward. It's an indoor handover I'm talking about. Okay. Mm-hmm. Okay, so I'm showing you the one which I prepared with the help of one set of audience. So if a patient is being handed over, this should be the minimum content of the ideal handoff. This is the basic. So I'll tell you how I do it with my, I think I've given this in the booklet. Have you seen in the booklet? Yeah, I've given this in the booklet. Yeah. So what I do in this, the activity that I do with the audience is, I'll first ask them to prepare their individual list. Then I'll divide them into 3 or 4 groups, depending upon the number of people in the group. So I'll ask them to come up with one common list after discussing with their team members. Once they come up with the final list, then I ask them to collectively prepare one list, which the 3 or 4 groups have prepared. So mostly they come out with very, good components of an ideal handoff. That way, one is you have their commitment, then there is a seriousness of doing it, and then third, they get to realize how it is important and why it is important to have these components in the handoff too. So if you are whenever you're doing this, normally you would require 2 hour session to cover this minimum. Even more can be spent, but at least 2 hour session, and there you can do this activity, take good half an hour and make them do this activity, and they get engaged in the activity. But I'm sorry, I'm not able to do it now because I want to really move on with this. So I hope this gives you an idea. Now you can check what all did you miss out of this. From your list you can see what all have you missed. So do you think that something more can be added to this list? Would you like to add anything else besides it?
Ma'am, I have something which may already be covered here,
Mhm.
but I'm not sure under which heading.
Mhm.
One is level of criticality of the
Mhm.
patient.
Mhm.
What are the critical components?
Mhm.
And are there any special requests from patient or attendant?
Okay, very good. I think that's a good district. So for example, this one we had kept for a very, regular kind of a setup, not like ICU or any critical care area. So if it is a critical area, I think your first point makes sense. The criticality of the condition, that can be, so that clearly communicates, okay, how serious is the patient right now. But yes, this input that any request from the patient or the family can be part of the, part of the handoff. Yes. Or maybe we can have an extra column where anything other than what is here needs to be added can be added, depending upon, whatever you think is important or relevant for the patient. Should I move further? Yeah, Dr. Santana, please go ahead.
Ma'am, can we generally put up the team, the care team or the doctor's team, because there is a possibility that there would be a shift from the current team where if I was a nurse, there was a particular doctor, maybe a physician, and then the patient has been referred to the cardiologist, and the cardiologist team takes over. So we can have something that which I have also put it up in personally in the box to you, the responsible team or doctor, if that can
Okay.
also be put up, added onto it.
So maybe in that they were probably you're saying the patient is moved out of the
No, the treatment, if in the same, if it's an ICU bed number 2, Dr. Santana is admitted, and
Okay.
if she's gone into respiratory distress, so from the physician, she has been transferred over to,
Yeah.
say, a senior pulmonologist, and then the
Yeah.
pulmonologist team takes over and starts continuing. So if that can be highlighted, because probably the nurse who was there earlier had handed over with, say, Dr. Shukla, and
Yeah.
now Dr. Shukla has handed over it the patient to Dr. Arneja. So Dr. Arneja's team is now responsible for it, kind of
So
a
very
thing.
true, that can be given. But if you look at point number 6, which says any adverse event happened, any intervention done or expected. So in this, maybe in case if that's the seriousness of the condition, then probably we can bring it here that this is what happened and the patient had this condition, and we had to call doctor from the other department and take the second opinion, and now that doctor has been roped in for the further treatment of the patient. I think that can be brought in this.
The treating physician's name or the treating surgeon's name can
So
be.
that's being assumed that if the person is admitted under one unit or one person, then probably that person, I mean, although of course we should be talking about that, but if you want to keep it to bare minimum and also the most relevant point, because what I did, I made them write anything that you think is important to be handed over. But then I said, keep only 10 points. Why I asked them to keep 10 points is, if you make a lengthy handover, then people are not willing to hand. That's why I thought, and the best way, what I would suggest in case if you are planning to implement anywhere, start with the smallest possible list. It will be easy for them to start. So when you give them an easy task, they'll be happy to do it. And slowly, one by one, you can keep adding, few items after every maybe few weeks or a month, depending upon how your team buys in. If you give them a long list right in the beginning, they'll say, sorry, I don't have so much of time to hand over. Everything I've written in the case sheet, why the hell should I be writing it again and again? So try to keep it as short as possible. I think that's what is my understanding about the handout.
Excuse me.
Yeah. Anything?
Yes, ma'am.
Yeah, please. Yeah.
Ma'am, whatever you have said is very true and very practical, because what has happened because of NABH and other things, and then a lot of paperwork, the right mix and match of patient care on the ground and the writing work. There has been a change in the paradigm in last few years.
Correct, yeah.
And even the patient see कि ये सिस्टर लोग तो हमेशा लिखते ही रहते हैं keep on writing. So when we go on rounds, so the major thing is कि the poor nursing staff, मतलब they feel pity on them, that then most of the time they are keep on writing, because the next morning the MRD team will come and point it out.
Yeah.
Then the quality team. So what happens ki the touch and what actually
Yeah.
was the care thing.
That is lost. The time is lost.
Is compromised, ma'am. Is compromised.
Yeah.
Because there is most of the time the organizations are not following the ideal nurse-patient ratio.
Yeah.
And but the protocols are given. So every now and then those things are levied, and they can't change the management's decision. So the nurse is at the receiving end, and the patient at the most receiving end, because the care
they lose the opportunity. Yeah. And a lot of time I get to hear from doctors and nurses कि मैम अब हम doctor और nurses कम रह गए, हम clerks ज़्यादा बन गए हैं. Because we are always writing or filling up the forms and completing the format.
Ma'am, I would just like to add on this thing, because otherwise it will be missed. After that direction that doctors should write, type the case sheet, the instruction. So I was at both the ends, before and after, and as a patient. So earlier the doctors used to write a long case sheet. If they write on routine pen and case sheet,
paper,
and when they type, so these are only 5 lines.
Yeah.
So that is how the work and things changes if you go more on
qualitatively and quantitatively. Yes.
Yes.
So you have to be really very pragmatic while making such changes, and be mindful of the consequences it might lead to, or repercussions it might have when you implement something blindly and you don't look into the possible consequences of it. That's the thing. Very true. Yeah. So this is another one simple 5 P's rule. I'm sure you all must have heard of, and in certain places this is really functioning very well, but in complex situation this is not sufficient. So 5 P's are: first P is patient, then what is the plan, what is the purpose, what is the problem, what is the precaution. So for example, I've given an example in this slide. So patient Ram, 54 years, to be kept empty stomach. So plan is to keep him empty stomach. Purpose is because of the barium meal test. Problem is that he's diabetic. So precaution is please check his blood sugar. Otherwise, in case if his sugar goes down, there can be a problem. But in complex cases, this kind of handover will not work. But number of hospitals are, not in India, but in Western countries I'm talking about, are still following this protocol, and they are finding it useful. But I think in critical care areas, this is not sufficient. So you require more detailed handover than this. Now, for example, I give you the same case that we read in this slide 1. If I ask you to hand over now, suppose if you have to hand over, how will you hand over? Just write in your case sheet first, and then maybe I'll ask one of you to present what have you written. Try, make an attempt.
Is it using the 5 P's only, ma'am, or
no, not 5. No, 5 P's is not a good idea. But if you think you 5 P can cover everything, you can try. You can try. If you think 5 P can cover everything, you can try. And once you have done it, write in the chat box so that I know we can start with the discussion. So who would like to try? It's all right. I'm not expecting any ideal this thing, but anybody who would like to try, Poonam or Beauty or Bindu or Isha, because all others I'm sure are still familiar with the way of handing over. So I want to see.
Yes, ma'am. That will be good, ma'am.
Yeah.
Yeah. I'll check mine.
Sure. Please go ahead.
Kishore, 14 years asthma patient is improving and will be discharged tomorrow after weaned off from oxygen.
Okay.
I've written short and crisp.
Okay. Okay. So according to you, patient's name and age and diagnosis is important. Okay. And then his condition, and then he's about to go because he's better now. And if you can wean him off the oxygen, then he can be discharged tomorrow. Okay. Good attempt, I would say. Very good attempt. Anybody else who would like to try their hands at this? Beauty?
Yeah, on similar lines only, ma'am. Patient name, age, so Kishore, 14 years old, who was admitted for asthma, mild persistent asthma, has been planned for a discharge tomorrow. But the point to note here is only this can only happen if he can be weaned off oxygen. So that is I'm giving it as a underlying point.
Yeah. So as a condition, if he can be weaned off oxygen. So Dr. Santana, you wanted to say something?
Yes, ma'am. Ma'am, I've just put it up on your personal chat box. If you allow me, I'll share it with the rest also, what I was thinking and planning about. I put the 5P.
Yeah, it's more okay. It's more like, okay, but you have put it in the, okay, you can go ahead. Yeah.
So Kishore was male, 14 years. The plan is to wean off oxygen. Purpose is to discharge tomorrow if asymptomatic. Problems, mild persistent asthma with URI, and precautions, wean off oxygen.
So in a way, you have done a good job by putting it under P. So you see, the moment you follow some system, things become more clear and systematic also. Now, the thing is, in this case, we have not talked about the amount of oxygen he is getting now and how much should be the weaning. What about the other drugs that you are giving him? Because we have talked about URI. That means the child must be on some treatment for URI. What about the medicines? Are you going to give them? Are they stopped? Are you going to reduce? See, that's what I'm saying. The picture appears very simple, but there are underlying issues that needs to be addressed. Now, let's look at this slide. So problem here is that we need to talk about asthma. Yes, the child was admitted for asthma. So what was the treatment being given for asthma? Have you reduced? Then what about nutrition? Child was on IV. So maybe the child needs to now move to oral fluid or liquid or semi-solid or whatever you want to give. Or for example, for hypoxia, if you want to tell about what is the present oxygen quantity we are giving and how much do you want to really reduce or wean off. And then in case the child is on antibiotics, because yes, the child was admitted for infection in the chest.
I think ma'am has got.
Yeah, I thought it was my connection. I can't
No,
hear
no, no. I think so. It's ma'am's connection. She should be back any moment.
Okay.
Ma'am is connecting back. I just called her up.
Ah, good. Thank you.
तो ये बेसिकली एडिटेड वर्क है थियोडोर बर्न्स एंड जियानी स्टैनले ने किया हुआ। इसमें कई सारे रिसर्च स्कॉलर्स हैं जिन्होंने कम्युनिटी बेस्ड वर्क किया है और इसके लिए उन्होंने कल्चरली डाइवर्स ग्रुप्स कम्युनिटीज उन्होंने चूज किए थे।
Isha, you are the host, so you can mute everyone.
साउथ ईस्ट एशियन कम्युनिटीज, यूरोप।
What was that?
I think so. I think Bindu madam had a mic on and she was talking to everyone. To someone else, I'm sorry.
More like when teacher is not in the class and then all kind of things.
So thankfully, we are not being the notorious kids.
We are too decent.
So I hope the new year is treating all of you all quite well.
Sitting quietly, all of us.
Finger on the lips.
Comparing, we are better from other places, listening about Delhi, what happening in Bangalore, what is happening in Chennai, and at Indore, it's okay. We are still not those kind of weekend lockdowns and all things. Different.
So Mumbai still has a lot of cases, but I can't see that. I can see still see a lot of people roaming about and a lot of them without mask. So I doubt whether Mumbaiites are really going to take anything seriously anymore, because now they feel that
It's
all of them are.
everywhere. Actually, in Delhi also, if you see, people are.
Okay.
Ma'am is still not joined, so we can still continue. Poonam ma'am.
Yeah, in Delhi also we can see so much chaos, all the markets, people are going from here to there and so many number of cases. In my known to circle also I have heard so many positive cases today itself. Chalo, ma'am is there. Ma'am is
Welcome
there.
back, ma'am.
Sorry, I don't know, it's very surprising. Normally we don't have any electricity failure like this, but then today it's been almost like 2-3 times in a day that has happened.
The participants have made full use of that break.
Wow, wonderful. So I should be having more breaks in between. Is that right? Just let me check if we are on the YouTube or not, because it's showing that it is on YouTube. I hope so.
Ma'am, as such, we feel that these 2 hours are less, ma'am, and that if we start having breaks,
I
Then
know.
we have had it.
We are
We'll
already
have to have
short of time.
20 sessions instead of 10.
I completely. You know, I was thinking that I really wish that you all have that, kitty of topics in your pocket, which you will be asked in the time to come. Conflict resolution, then team building, motivation, how do you get the right people in right place. So I was thinking that, okay, advanced level program should talk about these things rather than just the communication and interpersonal skills. But then let's see what happens. So let me quickly share the screen with all of you. Okay, so you made an attempt and you found that, making sense. Do you think that made sense? Where is the
Ma'am,
present?
actually, we made an attempt with whatever information we had.
Yes.
So maybe we could have thought out of the box and we could have done better.
Exactly.
So we
No,
were focused only on
I-
what information was there with us.
Yeah. So the idea was not to say that what you did was not enough. Idea was to tell that this is how this information never gets, noticed and discussed when we are handing over, taking over. Whereas, see, talking about asthma, talking about nutrition, talking about oxygen and infection and antibiotic is part of the treatment, which should have been handed over. But normally that's the usual typical handover that we happen to see. But this is what basic should be there in the handing over. That's the idea we are trying to capture from this. So I hope this gives you some idea. Also, contingency plan. Now, in case if the child requires more oxygen, then maybe we need to, or there's a, the asthma acuteness increases, then how do we handle it? In case if the child has fever, then how do we handle it? And what all? So that also needs to be talked, in the handing over, and then of course read back so that you know that the other person has actually understood what you meant to say. So is this making sense now? Is this making sense? Okay. So moving further from here, the understanding that we need to have that handing over is not passing the buck, but it is passing the torch. So it is literally handing over one, patient from one care area to, from one person to another, to the extent even the patient should know who is my attending doctor now, who is my attending nurse now. It's not just that we need to just know, okay, now I am taking over, but the patient also should know, okay, this is the next nurse who is going to look after me, so that I know whom I have to contact in case if I need to talk to it or, take help from. So what are the barriers that you see in effective communication between people when it comes to handing over and taking over? What challenges do you see in terms of, even if they try to hand over, why doesn't that turn out to be an effective handover? And can you quickly think of?
Time, I think one of the
Time is one of the
Time is one of the factors. Very true.
Ma'am, the timing of the change, like in the evening,
we have already
time for giving
discussed.
medication. If
Yeah.
you start writing, then the patient's time for sleep or something. So that is why
Yeah.
you have to finish those things.
But we are basically talking about handover between two people and what can act as a barrier in that situation. For example, one is human fallibility. You might forget. You may not realize how important that is to be told. Like, for example, that patient injection Lasix. The evening staff, before telling to the night one to give Lasix, could have confirmed with the doctor, should I give, I miss the medicine in the evening time. Should I be giving the injection or can we skip it? So it can be even error of judgment on the part of the person when you are handing over. Then systems are very complex. It's easy to sit and talk like this and say that people should hand over. But when it comes to actually hand over, there are a lot of challenges that people have. You may be very busy. You had a very hectic day. You had a very critical patient. And then if you have to hand over, everything, sometimes it becomes very difficult to actually implement them. Then there are limitations of learning and training. See, we are saying we don't have any systematic way, we don't have any training. Even in countries where they are giving training, how seriously it is taken, how seriously it is learned, even that has a big role to play. Then there are continuity gaps also. For example, there's a nurse who is taking over, and then the next nurse does not come, and another nurse is brought from another department to take over. She wouldn't be knowing what happened in this case, and because she has just come in. So there can be continuity gaps because of these kind of things. Then negative impact of fatigue and busyness. This we have talked already. Time constraints, you have already pointed out. Volume of information. Yes, it could be a very huge volume. It might appear very simple when we are talking about Kishore and we are talking about his hypoxia and asthma. But then when you look into the critical patients care, it's a huge amount of information they need to share. Then confidentiality can be a challenge. Sometimes some information should not be communicated or transferred, and there can be conflict whether should we be really handing over or not that information. And then there are also difference in styles of communication. Some people communicate fast, some people communicate slow, some people like to give lot details, some people like to give very minimum details. So there can be different ways of communicating. There can be gender differences also in communicating. Now, what gender differences are we referring here? So in certain cultures, men would speak very little, or in certain cultures, women would speak very little. So there can be gender differences in communicating. Even when you see giving details, some people, they have a culture of speaking very less or very little, and they would hand over or speak very little about the case or the condition. There can be cultural backgrounds also that can interfere with communication. Hierarchy of decision making, that's very important, and this I'm sure you all must be seeing in your system, and we'll talk about it a little bit in the next thing. And then level of respect between the physician and nurses. I think that's one area where we have a lot of challenges to face. And then level of empowerment. So when you talk about the challenges, between doctors and nurses, when it comes to communicating about the patient care between the doctor and the nurses, in your booklet, I've given you a very good example of assertion. So in that, it is the nurse who is trying to inform the doctor that the condition is deteriorating. What do you want me to do? And the doctor is very, aggressive about who are you to tell me to do all this. So you will see even these kind of situations, in your workplace. So there can be differences in style of communication. Maybe the language skills could be better among doctors, or, there can be even language difference. That can be a challenge. Hierarchy can be a problem, because the person who is at the higher in the hierarchy would assume that, okay, I'm not supposed to be said anything. Like Renuka said that when I asked doctors to follow a protocol, say we can't do it. So I'm sure Renuka must be finding a lot of challenge in convincing the doctor to accept this as a way of working. So hierarchy can be a challenge. Past experience can be a challenge. Suppose if you have tried communicating once and the other person has snubbed you, next time you will not feel like reporting anything or informing anything. You would like to keep it very brief and to the point. Then level of empowerment, especially when it comes to somebody from the lower position to the higher position, reporting or calling in or giving information, there can be a challenge or refusal to accept that. Tone of voice, we all know it plays a big role. Level of respect. So these are all different barriers that come in between, effective handover between doctors and nurses, nurses and nurses, doctors and doctors. So these are a couple of, tools. I've given these tools in detail to all of you, and I've kept it very, very simple. I'm sure. Did you get a chance to read those tools? And did you find them making sense, or was it very complex? Dr. Santana, did you have a look at them? I'm sure you must be already using it, and you must be training people in this. So I'm sure anybody who has challenged this, because I'm not going to spend much time on it. We want to move on to the two presentations that two of you have to make, but I'm just going to skim through the slides. So S bar, sign out, I pass the button. And there are many more handoff tools, and you can choose as per your requirement. So if I look at the I pass the button, I is when you are handing over, or when you're even calling somebody. For example, you're calling somebody from the other department. So first of all, you need to introduce yourself. Who are you? Then give introduction of the patient. About which patient are you talking? So you have to give the name, identifiers. It could be diagnosis. It could be, and also age, sex, bedroom, bed number, or room number, whatever. is the way that you want to identify the patient. And then assessment. So what is the problem that you want to talk about? I'll give you a few examples that will help you, to understand. And then situation. So what is the current status or current circumstance that you want the attention for? Then safety concerns. So what are your safety concerns about it that you are, asking for the other person's attention? Or whatever threats or pitfalls or alerts that you have observed and you want to report. So this is, I pass the baton. The baton is B is background, where you may also talk about patients' comorbidities. We'll give you an example. I think that will make it clear. Or any previous episodes or current medicines or family concerns, all that will be part of the background. Action is what actions are to be taken or you recommend or you are asking for. All that will be part of action. And then T, level of urgency. That means how soon that needs to be done. Is it urgent? Can we wait? Can we, do you ask the person to come as the person feels comfortable, or do you think it is very urgent and it needs to be attended immediately? So prioritization of the action. And then O is ownership. That is who is responsible for taking action. For example, if you think that it's the consultant who is supposed to be coming and attending, or the resident needs to be coming and attending. So depending upon that, you need to you need to communicate, or even if it is about the patient with the family, that part would be covered under ownership. So once we'll have an example, you will understand it better. And then N is for what happens next, or what is anticipated, or what contingency plan do you have. So this is also one of the handing over tools people are using in various parts of the world. Common one. Okay, this is the communication checklist. That means when you are handing over or taking over, these things you should keep in mind. One is when you are speaking, get the person's attention. The person should give you single-minded attention. Face the person, make eye contact, then person will listen to you. Use the person's name to whom you are talking and also about whom you are talking. Express your concern through verbal and non-verbal means. Use ISBAR technique. We are going to talk about ISBAR. I think ISBAR is being used most often. Am I right? In most of the places, ISBAR is the tool that is being used in most of the places.
Most simple to do effective communication.
And follow also. Very true. I completely agree. So in case if you think you need to reassert, there's no harm. Emphasize on what you want to say so that there's no communication, gap left in between. And then reach a decision. Okay, I'm doing it. Okay, wait, I'm coming, or whatever. And in case if you think things are not working, don't hesitate escalating it to the higher person. So for example, if you have talked to a junior resident and the person is not responding, talk to the senior person and then talk to the next senior person. Do not leave it unattended. So I just want to quickly give you an example. A patient, I think I shared that concern with you. And this is a case I've seen in one of the hospitals where I went for the training program. So a hospital employee's wife was admitted, in the gynae ward. She delivered a normal healthy child, brought back to the ward, and she said she had a sensation that I'm probably bleeding more. So she asked her mother-in-law to go and tell the doctor or the nurse on duty that I feel I am bleeding more. So the mother-in-law went and informed the resident and the nurse, and they said, okay, we are coming, we'll come. Once she went, then after 10-15 minutes again she went, but nobody came in. Nobody came to see what was the actual concern. By the time these people attended, that patient had actually gone into PPH. And unfortunately, we lost that patient. So even, for example, if it was the nurse who had seen, escalating it to the higher ups is very important. Sometimes we take things lightly and we think, okay, it will be all right. But you can lose a life if you don't, communicate, if you don't reassert, or if you do not escalate to the right person. So ISBAR is a tool that is used for sending a referral call. How in that, for example, if it's a nurse who is calling the doctor, telling about some urgent condition that she wants to be attended. So again, when you're making a call, introduce yourself, who you are, introduce the patient about whom you're talking, tell about the situation, tell about the background and the assessment, that what you think about the patient, and recommendation that you want to make or request that you want to make. And then that is ISBAR. Now, quickly an example for that. for example, if there's a patient with you, I'll give you an example in the next slide. So as I said, I is identify yourself, identify the patient about whom you are talking, bed number, room number. Then the situation, it could be a patient who is excessively bleeding, it could be a drug reaction, it could be change in vitals, it could be change in mental status, it could be the patient is stable, unstable, or is unconscious, or is glycemic, whatever. So that's the situation probably that you want to talk about. So background means you will also share some information about the patient so that the person on the other side can visualize the patient. Or this is a patient who has these allergies, or is hypertensive, or is diabetic, or high diabetic. So they get an idea about what this patient is. So you could even talk about the family background or this patient, because that the other person should be able to visualize the patient's condition. And then in the assessment, you will talk about what are your observations. It could be vitals, it could be the present condition, it could be sensorium, severity of pain, bleeding condition, skin condition, whatever is the immediate assessment that you have made about the patient and you want to communicate to the other person. At the same time, the recommendation or request that you think you want to make to the person, for example, this patient needs attention, so I want you to come and immediately see. Or this patient requires painkiller, or this patient requires bronchodilator, whatever is your recommendation, you recommend that. And that's how you talk about the patient, and also inform the other person how important and urgent it is to come and attend the patient. So this is one exercise that I want you to do quickly. I think not more than 5 minutes we can spend on it. I'm really sorry, but we really need to run quickly. So this is one case, for example, ward number 2, patient Raj developed skin rashes after he received his first dose of antibiotics. I'm sorry. Sorry. So he's type A diabetic, admitted today morning for wound infection at the appendectomy site. Anxious, looking all red and with rashes all over his arms and chest. Vitals are stable, temperature is normal. So what will come if I ask you to divide everything into ISBAR? Can you quickly say what all will come? If you can write in the chat box, even that's a good idea. Looking at the case, what will go where in ISBAR? Sorry. So if a couple of you have written, you can share with us. What have you written in ISBAR? So what will go in I?
I will contain, like for example, in this exercise, can communicate to the physician on duty, and the sister there should say from where she is calling and about the patient, and because as per her understanding, this can be case of anaphylaxis. So this needs immediate urgent intervention.
So first we'll talk of I. So I will be identify yourself and identify the patient. So I am sister so-and-so, or I am doctor, or maybe you are a junior resident and you're calling senior resident. It could be even that. So you could be a doctor or a nurse, but I am doctor so-and-so, or I am nurse so-and-so, and I'm calling about patient Raj in ward number 2 and bed number so-and-so. So that will be I. What is S? S is the current situation. So current situation is what? That I have given the first dose of antibiotic, or this patient has received the first dose of antibiotics. So that will be situation. What more?
I was under the impression that when I went through the notes, the situation was about the patient. You're calling out to which patient, and what is the situation as of now with the severity on Muse?
So what has happened because of the antibiotic, not because of any other reason. So situation is what has happened just now because of what?
Okay.
So this patient is diabetic, that's part of the background. Patient is admitted because of the appendectomy site infection, that's also part of the background. But the current situation is that we have given him a dose of antibiotics and he has developed, reaction to it, rashes because of it. So current situation is anxious and he has rashes on his body. Assessment is that his vitals are stable. Temperature is normal. And then you also want to bring about the point that his wife is agitated. That means that we need to immediately attend. Or what do you want me to do? Do you want me to give any anti-allergic? Do you want me to start with something? So that will be kind of the part of R. So you can see here, I can be, hi, I'm sister or intern or what, so-and-so. S could be, I would like you to come and see this man Raj, who has had a significant skin reaction to an IV antibiotic. So this is the situation. The rash has developed because of the antibiotic. The background is that he's admitted because of appendectomy wound, and he's a type 1 diabetic. And also we have given him the first dose of gentamicin, metronidazole and ampicillin. Assessment is that he's anxious and appears flushed with an arrhythmias, rashes on the chest and the arm, and his blood pressure is normal. That means vitals are okay, but then this is the situation. And R is that would you be able to come and see him urgently, or would you like me to do something in the meanwhile? So this is how. But if one knows that this is how I'm supposed to be, calling, then it becomes easy for the other person also to remember, to understand and advise you accordingly. So that's the idea of, so basically the idea is that these things should be slowly made part of the way of communication, and not haphazard way that we say, come and see the doctor, come and see this patient has problem. Not like this, but you are supposed to be giving some information. So those of you who are planning to, start implementing handoff tool seriously in your setup, the suggestions that I would give you is assess all points where the handoff occurs. It could be emergency, it could be ward, it could be dressing room, it could be injection room, it could be anywhere. And concurrently monitor processes at all points. So you'll get to see the gap. You will be able to see the gaps in the way they are doing. So conduct gap analysis so that you exactly know how the lapses are happening. Then identify people who can be your champions. They could be physicians, nurses, technicians also, if you are able to identify them. And then select a consistent approach to handoff. As I said, start with the smaller set of requirements. Don't ask too much, they will not cooperate. So have minimum basic things that need to be handed over. Let them learn it, let them, get used to it, and then slowly you can implemented. Then develop a policy and a procedure of doing it. Like I said, 15 minutes from both the shifts can be planned, that 30 minutes we are going to spend on handing over. Initially, maybe 10 minutes will be also be okay, which everybody will say, ठीक है, 10 minutes ही तो रुकना है ज़्यादा, क्या हो गया? Then slowly we can move on to 15 or 20 minutes. Then educate people why they need to learn, handing over, and why they need to take over properly. Implement the policy, monitor and report finding. That's how I think, I'm sure you already are doing it, but this is again, when you are training your audience, this is how you can tell them to, start implementing in their setup in a smaller way to start with. Benefits we all know of proper handover. There is continuity of care, patient safety is ensured, errors are reduced, repetition is avoided. A lot of time you'll see something somebody has done but has not signed and not informed the next shift. That procedure is done once again, or that medicine is given once again. And then, of course, when you look after all these, patient satisfaction will automatically go up. Now, if you have a standardized way of communicating, the best will be that the benefit will be that it is not person oriented, but it is a process oriented. So it is not focusing, on individual style of handing over or taking over, but then it focuses on the patient, that this is about the patient. And also the standardized format will allow all patients to have, one second. Yeah. To have common expectations, like what is going to be communicated, not patients, sorry, parties. You would slowly know what is going to be communicated. And then because you will slowly know the structure, then it will be easy for you to even clarify in case if somebody is missing something, you will remember to ask, okay, I need to ask about this. What about this medicine? What about the investigation? What about the referral that you sent? So people will know that this needs to be covered. And then everybody will know what are the required elements of, each communication, and we don't miss on anything. I think the take home message that I want to give you is that most of the errors in patient care happen because of the ineffective handing over. And if we remember that handing over is essential for continuity of care and patient safety, I think we'll not forget its importance. And when you are giving or taking handing over, be specific, concise. If you follow a structure and standardized format, you will automatically become more concise and specific in your handoff. And handover is never given, it is actually taken. So when you're receiving, you're taking the handover, make sure that you're listening attentively and also confirm and clarify in case it's something you are not clear about. And readback is a good way of, helping people know that how much you have really understood. So any questions about this? Yeah, please go ahead.
Ma'am, following these basic guidelines, we should, and as you said, we should learn the system and the gaps. For example, easier to understand to all from non-medical field also. Like during COVID times, there was a lot of hue and cry about injection remdesivir. So the patient's attendants were only concerned with injection laga ki nahi laga and those things. So and there was other lot of care involved.
Yeah.
So what I innovated in my setup, formed a team of other nurses just as an injection remdesivir team. So that they were only concerned about the that was a very costly and a lot of things was there. So only concerned with that injection itself. So taking those injections, going to patient bedside, whether it is first dose, second dose, and putting the wrappers and everything, and that record has to be submitted. So the other nursing team was devoid of all these things and was just concentrated on vitals, IV, nutrition, and other things. So again, if we could take the load and how we can increase their efficiency. Not everything on them. Okay.
Maybe even dividing the work between them so that they can. Good idea. I think that's another good idea. So that means I understand what you are trying to say. If we want to add some burden, we need to reduce some burden. That's another good way of, implementing something new. Because if we are going on, especially with NABH and JCI, a lot of things are being, pushed on them. But if they are not able to really, manage it, then definitely there will be mistakes and also kind of more of a paperwork than actually doing it in real sense.
And ma'am, another thing is like we are living in only one world, that is medical world.
Yeah.
So if you able to move them from their world, and if you want that they should learn and inculcate, so like we should expose them to like the firefighting team, or there is a rescue team where a crash happens in a military base, and if you see their things,
efficiency
you'll
in
be
the way.
amazed. They are sitting idle at the crash bay, playing carom, whatever it is. The moment there is emergency button, how they respond and how they hand over. So we the interdepartments learning will make us understand how important.
Learning from the other industry. It's a very good way of, very good. I completely agree. Thank you so much. So any questions? I think I want to ask ask others if they have anything to ask. So Dr. Samira, any question about what we have discussed?
Really, it is very simple and well-structured tool, ISBAR, and very easy to use. If we can train our staff, it will be so beneficial.
Yeah.
Yes.
ISBAR, and even that, 5 Ps to start with. I don't mind even if you start with 5 Ps. Slowly you can add A, F, B, C, D, whatever you want. But only thing is they should become familiar with the idea that there has to be a structure of handing over. So even when we do cleaning, I think at home, we have a way of doing it. We'll do one thing first, and then second step, and then third step. And if we mess up, then we realize, oh, that was not the right way of doing it. So I think that's the way they have to be really sensitized, that if you'll do it, systematically, you will be more structured, and, you will rather save time and energy. I think that has to be emphasized. And I think everybody who is into healthcare needs to actually demonstrate how do you go about doing it, so that, they slowly buy in whatever ideas you are trying to give them. That's it.
I think while telephone communication, this ISBAR is very correct. In fact, I had done the chat wrong and I put I for the patient itself. It was actually introduction of the staff and then goes with the thing. And it comes. And for writing handover, we use just SBAR.
That's good. Wonderful.
Only the SBAR part.
You don't require I because you
there. Yeah.
No, but
the
when you are sending a
referral,
when you are sending a written referral, there you need to identify, it could be at the end. Who is the signing person, then your stamp and name in capital, so that the other person knows who is calling, who is sending the referral. But I agree. In regular receipt, you don't always say, okay, I'm nurse so and so and I'm handing over the patient to you. That's not required.
Just put that handed over, take over.
Yeah. Very true. Very true. So very quickly now moving on to the next thing. So we are left with just 10 minutes today. Everybody will have to, I don't know, Renuka, I really pity you. How do you, pardon me for
no issues. We'll finish. We have just 2 more sessions to go.
Yeah. I know 2 hours or less. 2 hours or less.
And to imagine that I thought first it was 5 sessions for 2 hours each. I had got that thing. Totally, it was 10 sessions.
So, okay, between Gurleen and Renuka, whoever wants to, present first, please decide. Kaun karega pehle?
Yes, it's okay. Shall I?
Go ahead, Renuka. It's okay. Go ahead. Yeah.
Okay. Ma'am, then you will have to just make me the host. Just a small and quick presentation, and if you can.
I have enabled. I've enabled you. Yeah.
So how does it come?
So now you can, if you share screen, it will allow you to share screen.
I'm not getting the option here.
You're not getting the option of share screen?
Yeah, I got it.
Okay, yeah.
Sorry.
The share screen green icon is there down, and if you can keep your PPT open in the background, it will become much more easier for you. You can just go and click on the PPT. Renika, you can manage it? Or you want me to call you up and help you out with it?
I thought I had the PPT open. Just open the PPT and I'll just share it. Sorry for the delay.
No problem.
Is that okay?
Yeah.
Clear now? Yeah.
Yes, yes, yes.
Hi all. And
Please select the screen, the slide.
Yeah, slideshow.
Yeah.
okay.
Perfect.
Yeah. So quickly I'll go into the topic. The topic given to me was ice breaking sessions. How do we do it? So when we are talking of ice breaking sessions, I just wanted to, quickly come to the point and how we are going to do this. So I just thought a simple way of taking this whole session forward will be with how we conceptualize the whole thing, which is like 5W and 1H. So if I can quickly ask Hemant sir, what is ice breaking session?
To just start off in a great way that everyone is concerned and accumulated to that talk.
Okay.
One of
Okay.
it.
Okay. Beauty, why do we need a ice breaking session? Can I see everyone? How do I see it?
Because if we have to work together, we have to gel together. Can you hear me?
Yeah, I can.
Yes, yes, yeah.
Am I audible? Yeah. So if we have to work together, we can't be like living in two separate cubicles. We have to be together in a single place, connected both emotionally and intellectually to be able to learn together and whatever is the agenda. So to fulfill that agenda, we have to learn from each other. We have to work together.
Okay, so we got the what and the why, and who does the ice breaking or who was involved in an ice breaking session? I think it's a very direct question. Samira ma'am.
Or the facilitator would make the ice breaking.
Yeah, so the facilitator and the target audience whom we are talking about. Okay, and when is an ice breaking session done? Santuna ma'am.
So ideally, whenever you're putting in a new concept, or when there is an introduction of some new systematic procedures in an organization, and when there is a new joinee in the hierarchy of the organization, then we generally have an ice breaking session.
Okay.
So like a new CEO joins or a managing director joins, he wants to, so that people get familiar to him or her.
Okay. So, yeah, as you rightly said, in a program schedule, when we are having it at the various times when you are introducing a new concept and you want to pitch in or through getting the team together aligned with the whole concept, you want to do it. And as you said, the various situations across the things where you want to get the team aligned. So, where can it be done? Gurleen? Is there?
Yes.
It's all in grid format, no, so my PPT is also on, so I'm just trying to see who is there. Sorry.
Where can it be done? I'm not sure I understand where.
Yeah, so I think even I was thinking about it. So maybe we can simply put it, it's in the physical format when we are meeting in person, and as a virtual format where as we are doing it now. And ma'am has been conducting so many of these things throughout. So where is what I understood with that. So now we come to the more pertinent. So what we are clear now, why we need a ice breaking session, we are clear who is going to do it, we are clear when we are going to place an ice breaking session, we are clear where we are going to do it, we are clear. How? Now that is the key part of it. So how are we going to do the ice breaking sessions, or what and all is involved in that, in the how part of it? Bindu ma'am is there?
I don't know. I don't think. Let me check.
Okay. Poonam ma'am is there?
Poonam sent a message that she's not able to log in because of some laptop issue. I think both of them. Isha is there, yeah. I'm not sure if Isha can answer.
Yes, ma'am.
Yeah. Okay.
Yeah. So
Yeah.
how is an ice breaking session done? So what are all the components which come? What exactly comes under the concept of a how of ice breaking session?
As far as I can think of, first of all, first we need to establish a rapport.
Okay.
And then giving a good if in put in my term, the psychoeducating the person, ki what exactly happened, the procedure, the management part, and the how is gonna be placed.
Okay. So
Yeah.
it's basically the methodology behind it, right? So how the whole program you're going to structure, how much time you're going to give to it, what are all the activities you're going to involve in this. So that will come to the methodology or how you're going to structure an ice-breaking session in that. So now when we come to it, the whole thing, the concept that I think Beauty said was to make people comfortable. I think she only mentioned, and to make them feel happy about being part of this whole program, as is what we are working towards as an ice breaking session. So there are definitely some do's and don'ts involved when we are talking of ice breaking activities. When you're conducting a mass program, say now we are just 10-15 people, when you're doing 30 people, when you're doing a national international level program, or you're meeting people with different cultures, what are the things that you will keep in mind as a do's and as a don'ts of the program? Can someone quickly tell? Gurleen? See her face. What is the do's and what is the don'ts? Whichever part you want to take first, you can say.
The do's would be to engage everyone, to feel comfortable at ease, to ensure that everyone participates.
Yes. And anyone else?
So maybe one of the do's would be to keep it simple and easy to understand and follow.
Very simple, very true, very true. Keep it as light as possible so that it's
Yeah.
common for everyone to understand. It's not very
easy to
high funda or
understand and
something.
follow. Yeah.
So,
Light and humorous.
Yes.
Anurikaji,
Yes, something fun, something light, not very
Fun,
intense and scientific. Into something.
And don'ts would be
involved.
to be culturally sensitive, not to use remarks or
Not be
something that is culturally inappropriate.
Not to make anyone uncomfortable in the whole process, or not to make any personal situations, like even nowadays talking of marital situation is a big thing. You never know what's the background
Gender,
behind.
even gender.
Yes.
Yeah, even
You don't
jokes
know
on
what.
gender specific jokes are not acceptable.
True. So don't make it personal. Keep it as light and fun as possible. Involve everyone. Like in maths, we have lowest common denominator. What applies to everyone across borders, across. So that is something which they can do. And also somewhere you get in some concepts which can connect to them on a personal level. So if I simply ask, what's your favorite food? I think everyone starts saying like, they have their
I
connect.
think we missed the first and foremost point is of introduction. Like you introduce yourself and you let others introduce themselves. I think we missed that element of introduction.
Yes, in fact, even the thing that you say that, okay, my favorite food is, and then you first come forward and say, okay, I like ice creams, and then the other team follows. So you're putting yourself in a situation like they kind of relate to you or start relating to you as a facilitator, and then the others also, start joining. Ye nahi hai ki, you're one step above and the other one. You're putting everyone on the same platform, and that's the common objective, or that's the understanding of a typical ice-breaking session, where you get people together and to connect and get that rapport together. So don'ts is very important. We ensure everyone is happy in a happy space and on the same level, and not any personal contextual things are done on that. So basically you encourage the self-expression of a person, correct? Ensure you put in questions or puzzles or games or which can be answered by anyone, and you build up the personal context and avoid any yes or no. यहाँ पे कुछ सही गलत नहीं है. मतलब it's all like you can tell whatever you want. There's nothing. No one is judgmental or going to be judgmental about the whole thing. Be mindful of personal questions and don't make people feel inadequate or incompetent about them. So, like even if you have an activity, don't score like, okay, this team came very low and this nothing like that. Just
very discouraging.
Light and happy about this whole thing. We did discuss about this physical and virtual space. So when we come to the how about it, what are all the methodologies you have for doing the role play, ice breaking sessions? What are all the activities that you can think of? We have been doing so many over the past few days. So quickly, can someone just summarize? Simple things like role plays. Is it an ice breaking activity? Yes.
So maybe initially
quick game.
start with people will not open up. So maybe role play can be reserved for
Last, yeah.
later part.
Group
After some time.
activities can be a
Group
part of it.
activities. Okay. Some
Or maybe
teams.
small thing which allows people to slowly become comfortable, because not everybody opens up easily. So you will have people who have, a lot of reservations speaking in front of others or sharing their thoughts. So we have to really be mindful of the fact that people may not open up easily.
So how do we structure it? Can we say like we can start with simple things like just introduction, and then go on to some common one-liners or common games, simple games, then team activities, and then role plays? Is that how we can progress through this?
Yeah. So in a physical setup, I think making them do some physical activity.
Okay.
And preferably in pairs.
Okay.
That makes sense, because then they would, then they don't have to connect with everybody. They have to connect with one person. So it's easy to connect with one person and, start participating. And I'll talk about the psychology of it after you have finished.
Okay.
I guess this occurred to me, so I thought I must share with the group.
Okay.
How does it work actually at the psychology level? Yeah.
Okay, so you connect one-to-one, and then you go on to a team, and then you have the various role plays. Any other inputs, from anyone else?
There are a lot of hacks available. Like there are a lot of games that we can play. Sometimes the game will need to modify based on the kind of group we are addressing to.
Okay.
Simple things like having a card game. So you have 5 cards and you ask 5 questions and you ask everybody to answer those 5 questions. Or there are games that you can play where they have to, they can answer without revealing their names, and we get to know interesting stuff about each other.
Yeah.
Okay, good.
That's an interesting way. Yeah.
That's a nice one. Okay. Depends also on the kind of audience that we are having, right?
Group.
Kind of space, the thing we are addressing for the day. Right? Yeah. Anyone
So
else?
when you're doing activities in healthcare setup, my observation is, if you go for too, elaborate an activity, sometimes the seriousness of the issue gets diffused, and people might take it like more like fun way. And I've seen a lot of trainers actually using a lot of activities just to, engage people, but then that doesn't become fun. It becomes funny. And then at times the message that you want to convey also gets lost in that process. I think that's something we have to be mindful of. And also I was thinking that we should not be forcing everybody and anybody to participate. So there will be people who will not be willing to participate. Especially when you're doing ice breaking, because mostly ice breaking is done in the beginning. They can be encouraged, they can be motivated, but they cannot be forced. And we should avoid doing that, because then they may become resistant and may, aloof themselves.
True. And I think very rightly you said, ma'am, and the other thing was also the time factor. How much time we allocate to it.
Yeah.
So each activity, see, sometimes what happens, some team will get very excited, or one particular person very this thing, and they may just keep on talking, whereas that will sidetrack the whole thing and out the whole thing. So basically keep your activities around 5 to 10. There are many on Google. I was searching for activities. Many are there. We can find out a lot of ice breaking activities. They have various levels, like from school level, college level to office meeting programs. And as ma'am said, most of these corporate workshops, even I have attended 1 or 2, they just run on ice breaking activities. There will be not much or content inside the whole. But they will be just doing only activities, and the content will be less. It will be more of all the fun.
Then carry home message is lost.
Carry home messages.
In that process.
We are basically designing our program, I think, as
Idea is that we want people to open up and to participate.
Yes.
And that's the objective.
Yes, keep it aligned with the objective that we are having as the point of discussion, and then we allocate certain time, and as Santwana madam also said, introducing a session or introducing a topic also, we can use ice to get it forward. So this was about the how part of it and how to get it done. So either physical and virtual space. Virtual, I was seeing it very nicely done here, and this was one concept I liked here, where we are blanking out all the other screens and only the 2 participants are on and doing here. That was one thing which I saw first time here. Any other inputs on virtual space apart from putting in rooms and putting in anything else which can be done on a virtual space? Anyone else? Ma'am, Gurleen.
I think using breakout rooms is also a good way of, having ice-breaking activities.
Okay.
I feel people become more, like they open up faster when they are interacting one-on-one with the...
Yeah. So this is what I wanted to talk about it. I have just quickly put some puzzles in so you can all answer. I think I'm able to. Everyone else is there, ma'am.
Yeah. We are 9 of us except Bindu, I think.
Bindu,
Bindu is not
okay.
there, yeah.
So what do you see here? Quickly, and then we'll move forward. So what do you all see here?
I can see
we
three
see-
images.
Okay.
There's an old man, there is
Okay.
a lady, and
Okay.
there is another man who is offering something or is pouring down something,
Okay.
which appears to be near the nose of the old man.
Okay. All of you saw? All of you saw the image?
Yeah.
Yeah.
Because when someone points out, we will see. Otherwise, we'll see only one part of the image.
Yeah.
And here, how many faces are there? I think one picture. So let's see how many of you count.
3, 4, 5, 6.
1, 2, 3, 4, 5,
तो 8 दिखे
7, 8,
9. Mhm.
9.
correctly.
Yeah.
1, 2, 3.
I can see 11 as of now.
1, 8, 9.
I'll still try to look more.
10. I can see 10.
7.
9 with
Sab ginti karo. 1, 2, 3.
but
I think I can see 11.
9 with Bal Gangadhar Tilak and Indira Gandhi, the politicians that
5, 6, 7, 8.
11.
मुझे 9 दिख रहे हैं अभी.
I can see 11.
Yes, I could see one more 10. Oh, yes.
So on,
Yeah, I can also see
either
10.
side of the branch, I
10.
can see a face. Either side of the branches, I can see one
Yeah,
face.
yes.
So there are 11 in total.
Yeah.
Okay.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and 11.
Okay. Poonam ma'am, Sameera ma'am, can you see the faces?
मुझे 11 क्यों नहीं दिखा?
Sameera ma'am, you're able to see the faces?
I can still see.
I can see
10.
9.
You can see 9. Okay. Beauty, you were saying something. Sorry.
10. Yeah, I can see 10.
Okay. Isha?
9.
Hemant ji?
I can see 9.
I can see 10.
Okay,
I
so
can
what
see
I see,
10. And the political, the leaders are shown here. So that is
So
also
now
one
we are
thing.
only in mathematics, not in history, geography. Because I will not remember the names of the. I know they are famous people, but okay, Santana ma'am, can you just?
yeah. So
Yeah.
I am reconfirming it. What I thought it's like a face is not a face. So I can see 10 now properly.
Yes, 10.
Distinguished
10 now
10.
properly. Okay.
Thank you for confusing me and Indu ma'am. I'm still finding the 11th face.
That has given a food for thought. Okay, let's count it again. Maybe I could see something out of the blue.
I hope you are not counting our grid faces, you know.
No.
Okay, so 2 on top. 1, 2, 3, 4.
Yeah. I think on both sides of the branches, if you count, then you have 10. Correct.
Okay,
Yeah.
good. Okay, so next picture, this is illusion picture, right? So where is it moving? Clockwise, anti-clockwise? Gurleen is already not feeling well. She'll scold me. Taking her time. Is it moving or not moving?
Anti-clockwise. Yeah.
Why is it not moving for me?
Yes, good question. Which wheel is moving?
Oh, so
Which wheel is?
when you
Both
look
wheels
at
are
one,
moving.
the other one moves.
Okay.
Yes. So whichever wheel we are looking towards, that particular wheel starts moving anti-clockwise, while the other one, because we do not have a fixed gaze on that does not move.
Indu ma'am is seriously lost, I think. She's just giving up.
Honestly, I'm not able to see anything moving. Chalo, koi baat nahi.
It is moving.
For you, not for me.
No, itna focus se nahi dekhna hai. Just light gaze, and then you see it moving. If you see it with focus, it won't move.
When I look at word bicycle, I can feel that there are both the wheels which are moving in anti-clockwise.
Yes.
When I'm focusing on bicycle word. and not on the both the cycle wheels.
हेमंत जी, आपको कुछ मूव हो रहा है वहां पे आपके स्क्रीन पे?
Both the very rightly said, when we see bicycle, both the things are moving. So there is a lot of movement in the screen.
Oh, great. He has summarized like a typical top senior level administrator and finished the meeting.
चलो आगे चलो आगे चलो.
Yeah. Now what's the word here? What is the word?
Optical illusion.
So both can be
Illusion.
seen. Now
Optical
Indu ma'am's
optical
eyesight
illusion.
is working. So optical is inside, illusion is outside. How many vectors are there here?
Oh. यार ये बहुत confusing है.
Yeah, back to mathematics. How many decks?
4 ही होते हैं तो 4 ही होंगे.
Officially, it looks like 4 legs because of the
Yeah.
entire foot if you count.
Okay.
4 ही है यार.
Yeah, it's 4 only. I think it's just because bottom part of it.
ये confuse करने के लिए पूछा है question.
Exactly, Renuka, it's a part of the activity because by this time people start thinking there is something which is hidden, and we should start identifying that, and immediately people jump up with their answers saying, yes, I can see 6, I can see 7.
Like Santwana said, I can see 11 faces.
So you're making the task difficult for yourself, and more involvement from the team. So good to see you all doing all these activities. That was just a gist of. There are so many activities on the net. I mean, all of you will definitely get it. And the last one is something which I all wanted you to do. It's just a part of it. Maybe you can even write it in the chat box. Give one reason you feel is best for becoming a great master trainer. According to you, what is the great? So with that, I will end this session, ma'am. That's all from my side.
Wonderful.
In the chat box, well and good, or you can tell it orally also.
The reason for ourselves to become a great master.
Yes, what do you feel is one attitude or aptitude you should have कि एक अच्छा master trainer बने? Some of you are already are, some of you are on the way. What made you take this course is your personal reason. What you feel could make you the best master trainer, you please write. You can tell it orally, you can write it in chat box. Anyone? Whichever you.
With your experience of the system, and with how you want to make a change in the system where you have been looking after just the problem areas, so you can be looking into that, resolving and making a change in the system.
Resolving and making. So in just 2-3 words, if you say you want to be the aptitude of resolving issues will make you a good master trainer. Okay, Santwana ma'am.
I would always say the same thing for which we are here: the excellent communication skills.
Excellent.
Even if it's a very basic topic, or it's a very complicated topic, if your communication skills are very strong, but this is I've learned it from Indu ma'am. You make a very difficult topic so easy that people can understand it very well. So that's communication skills are very important.
Communication skills. Okay, so resolving problems, communication skills, beauty.
So one would be staying focused on your goals, and second is willingness to solve problems.
Okay, solve problems. And
willingness to solve problems of healthcare.
Okay, Samira ma'am.
To make a change in communication style in healthcare.
Great. To make a change in communication style. And who else is there on screen? Isha is there? Isha?
Yeah, Isha has left. She had some work. She has left.
Okay, Poonam ma'am is there?
Poonam is there, yeah.
Was she part in the activity? She was there. I think she's.
Poonam was partly there. I think in between she was logging in and logging out. Yeah, so but she's there. I don't know if she's able to speak now.
Yeah. Gurleen?
Yes, I think willingness to learn, because we're in such a rapidly evolving and dynamic learning system that I think a trainer needs to be willing to learn and sort of remain updated.
Yeah, true. So learning is always a part of a growth of a trainer, right? Indu ma'am, your inputs ma'am, and then we'll close the session.
So I would say, I think you need to really keep updating yourself. Never believe that you know all. Never move with the idea that I don't need to, I'm at the best of the thing. No.
Very true.
I was thinking that anybody who would take a year's sabbatical, somebody who has taken 6-7 years of sabbatical, I was thinking that person will not be able to catch up with things. I mean, the way things are changing at such a fast pace, even if you take a break of, say, a year or so, you're out of market, out of picture. So I think keep updating yourself. That's the way you can stay, a good learner and a good trainer.
Yeah, true, very true. So thank you so much. This is what I wanted to convey from my side.
Thank you, Renuka, for such a wonderful session. Thank you.
It was a very top-notch effort. We just felt into like after Indu ma'am, another we have got a great
Ma'am,
yes, she is.
ये तो मेरे को आइस लग गया अभी.
Wonderful. Thank you, Renuka, for such a wonderful presentation.
Thank you, ma'am. Thank you so much. Bye.
So if you can stop sharing. Just one point I want to add here for everybody.
Yes, ma'am. Yes, ma'am.
See, ice breaking activity, the purpose of the ice breaking activity is whenever you enter into any program or any activity, you're very conscious and you have a habit of, evaluating people. That's how human mind functions. We have a, and usually we are thinking on the negative side, how much he knows, I know more than this is waste of time, I have such an important thing to do, why am I being here? So the people are skeptical when they get into, they come into the picture. If you are able to engage them at an activity level, that rational mind get masked by emotional mind. Because when you start enjoying something, your emotional mind gets activated. So it kind of hijacks the rational mind. So as a result, the person starts becoming relaxed, less skeptical, less doubtful, less suspicious, so slowly that person opens up like you and me, and they would become relaxed. So many of you, when you started your journey with me, maybe doubting, what are we going to learn? We are already so good trainers. We are so experienced. What is there to learn from this? It's not me or anybody teaching. It's all of us learning and teaching each other. But then somebody has to play the role of a catalyst. So anybody who does the ice breaking, who facilitates, who is a trainer, has to play the role of a catalyst. You don't have to know everything. But you just need to be good at, bringing all the wisdom together and making people comfortable to open up and talk and share their even, vulnerabilities and their challenges and their issues. That's the benefit of having an ice breaking activity.
Thank you. Nice. Good.
Thank you so much. Done very well.
Thank you, ma'am. Thank you so much. Thanks so much.
So it's already 10:20. So one is that Gurleen does it. But another thing is, Gurleen, we are, how many of us are there? We are 7 of us. So that means 3 people have left. So would you want to do it today or you want to do it next time?
It depends on you, ma'am, honestly.
If you are okay, then I would prefer everybody to be there, because these are very important skills we need to learn, or not all of us are good at it. So it's not just for the sake of doing. I want actually people to go back with the idea, okay, this is one thing I can integrate in my program and make my program more interesting. So if everybody is okay, I think we'll not do the second presentation now. Gurleen, you will have to do it the next time, because I want everybody to benefit from your topic. It's a wonderful topic, what you have chosen.
I think she'll also feel better by that day. She was looking a bit down.
Thank you.
So I think we need to close the session. It's already 11:20,
Yes, ma'am.
sorry, 10:20. The next session will be on 8th, that is Saturday. And then the last session will be on 11th, the date we started.
Oh, okay. Done. 11th is Tuesday?
Yeah, Tuesday. So coming Saturday and coming Tuesday will be the last 2 sessions. And one Gurleen will present, and I'll ask one person more to present. And then rest others can present on the last day. But I want you to tell me on the last day, do you want to have the presentation, or do you want me to take a topic?
Ma'am, we would prefer you to take the topic.
Yeah.
Because we want to learn more and more from you.
Correct.
Then the assignment would be more like a homework. After you all submit me, certificate will be dispatched only after you send me the assignment.
Yes, ma'am.
Okay. Yeah, we'll keep like that, ma'am. Yeah, that's it.
I hope that's all right.
Yeah, that's fine.
Okay, then.
You have to go through our assignments, what to
No
do.
problem. My pleasure. My pleasure. My pleasure. My pleasure.
Ma'am,
Yeah.
on a lighter note, at times I feel that you are coach of a team. You tells two batsmen to pad up. They don't know who will go first, and go ahead. And then the second person is all geared up. Then he is not at the when he will bat. So this is again testing great.
We all have to learn to be flexible.
Plan A, plan B, whoever is there.
Okay, I'll tell you just last 1 minute I want to share with you. Yesterday I had to take a session for Delhi Judicial Academy for the judges. So they were newly inducted judges and they were senior judges. It was a foundation program for them. So good number of them, I think 50, 60 of them. So program was supposed to start at 10:30. 9 o'clock when I was going to take bath, electricity failure.
Oh.
Never happens. Never it happens. Within 2 minutes, it resumes. So I thought, aa jayegi 5 minutes, it's just what is there. So I just started, taking out my clothes that, okay, then after 5 minutes, I had a feeling it doesn't take this long. I went to my other portion. So we have different meters from different poles. So I saw that there was electricity in that portion. And then what is this? I went down and I saw the meter wire had actually fused completely, Oh my goodness. And this is my setup, my table, everything is in this room. I've reserved this place for my official work. I didn't know that for it, but then I said, no, nothing can stop me from this thing. So in one of the portion where I knew there is electricity, I connected 3 extension cords, one after the other. I set up my everything. My husband said, don't worry, I'll get the electrician. We called 5, 6 people, but 9 o'clock early morning, either they don't pick the call or they'll say we'll come after 10 o'clock. I said 10:30 is my session. I can't take a chance. I was ready with my second setup, with 3 extension cords. And then there was electricity by the time my program started. But trust me, had I been, who would be apprehensive or upset, then I would have spoiled my program. And the best part was I took 1 hour session, not even a single slide. I didn't use any slide. It was all through discussion and activities. And everybody had their camera on. So I was happy, they were happy, everybody was happy. So Gurleen, the reason that you are ready now and relaxed. So next Dr. Samira, I hope you are not thinking that these people are joking in the middle of the session.
No, it's too nice.
That's how I normally, conduct my programs. And
my son has started peeping twice, so I'm leaving
go
back.
ahead. Good night.
He's already looking what's up.
Thank you so much. Thank you. Bye-bye. Good night. Thank you. God bless you all. God bless you all.